Thank you for joining us for the Navigating Medicare's Quality Payment Program webinar. Today we'll be focused on MIPS quality and cost categories. This webinar is brought to you by the Physicians Advocacy Institute in collaboration with Healthsperian. I'm Ray Quintero and I'm joined today with my colleague Priya Lamba. The Physicians Advocacy Institute's mission is to seek to better understand the challenges that are facing you as physicians and the patients that you treat, as well as to educate policymakers about these challenges. And the PAI's board of directors is composed of former as well as current CEOs from across the countries representing your state medical associations. Healthsperian is a Washington, D.C. based consulting and legal services firm that is focused on public policy, strategic issues, operating at the intersection of business strategy, operations, and government affairs. And today we're happy to talk to you about a macro educational series that this is a part of. The purpose is to provide materials and resources that provide you with context and an overview of the core concepts and requirements and an in-depth discussion of important topics. We'll also be providing you as part of this series a macro overview. In addition to that, the series will provide you with follow-on products in early 2017 that will include in-depth one-pagers and monographs focused on topics including MIPS scoring as well as strategies to assist you in reporting successfully. And in addition, we will be developing a guide to additional resources that are available to you in physician communities. As you are working to navigate your way through the QPP, there are multiple acronyms that will be thrown at you and that will become confusing as well as familiar to you. These are available to you on slide number 6. We won't go into detail on each of these. However, these will be a great resource to you as you continue to navigate through the QPP and as we work through this webinar with you today. What you will find in this presentation today is an overview of the MIPS program briefly. We will also talk to you about your transition year minimum reporting options for this year, which is 2017. In addition to that, we'll be going into detail on the MIPS quality category as well as the MIPS cost category. We will also talk you through the reporting timeline, and then we will conclude with a discussion of next steps as well as looking forward, as well as provide you with some commonly asked questions and answers that we've received thus far. To begin, we'll provide you with an overview. Who does the QPP affect? It affects each of you. The program will eventually include almost all clinicians who are billing for Medicare Part B services. However, this will be phased in over time. Eligible clinicians are defined as physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists. And all of you are subject to MIPS in 2017. In addition to that, this list will grow and be expanded in 2019. And you can see the additional eligible clinicians on slide number 9. In addition to that, there are some eligible clinicians who will be exempt from MIPS, and those that are exempt fall into 3 categories. The first of which are those that are newly enrolled in the Medicare program and who have enrolled for the first time during this performance year. Secondly, those physicians and/or groups that fall below a low volume threshold. The low volume threshold is qualified as either those who have Medicare Part B allowed charges under $30,000 per year, or those who provide care to 100 or fewer Medicare Part B patients. And the final category to be exempted from the MIPS program are those physicians who are participating in advanced alternative payment models. CMS estimates that over 32% of eligible clinicians will be exempt from MIPS in 2017 as a result of the low volume threshold. And CMS will be making an NPI level lookup tool available on the QPP website later this year that will assist you and other clinicians in determining whether or not you fall below the low volume threshold, to determine whether or not you're excluded from MIPS participation. So it will be important to revisit the QPP website to determine if you are exempt or if you are required to participate. And if you are required to participate, you will face penalties otherwise. And physicians should keep record of the eligibility and exemption status once you are provided that by CMS through the QPP website. And now I will hand it over to my colleague Priya to talk about participation options for you as physicians.
Thank you, Ray. So there are two participation options for physicians for the MIPS track. Physicians can participate either as an individual or as a group, but they must participate the same way across all four categories. An individual means the physician will report under an MPI and associated tax identification number, or TIN, to which of the practice to which they reassign their benefits. You could also report as a group, which is two or more physicians, so two or more NPIs who are part of the same practice with the same TIN. There are specific reporting requirements and alternative options for larger groups of 25 or more physicians. The key thing to note is that when participating as a group, you would receive the same aggregate scoring and corresponding payment adjustment across the group, regardless of your individual performance. Whereas in individuals participating as part of a group, if you have each physician in the group participating as an individual, then each of those would be, each NPI 10 would then be assigned a separate payment adjustment. But at the group reporting level, it's the same across all NPIs for under that 10. Another thing to note is that you must participate for each NPI 10 combination that you have. So if you have reassigned your benefits to multiple practices, two or more, then just keep in mind that you must meet the MIPS reporting requirements or the advanced APM reporting requirements for those other NPI 10 combinations. And you can also reassess whether you exceed the low volume threshold or are exempt from MIPS for each of the NPI 10s that you do have assigned to you. There are four categories in MIPS. You have quality, cost, advancing care information, and improvement activities. In today's session, we will be covering quality and cost. We will be covering advancing care information and improvement activities in a later session. Quality builds off of the PQRS program that has been around for several years now. However, the reporting requirements have changed. You have gotten rid of the measures group and replaced it with a measures set. But the reporting thresholds under that are different. And you must also report 6 measures, including 1 outcome measure. The primary factor for MIPS is the quality category early on. It is 60% of your score for the 2019 payment adjustment. Remember, there's a 2-year gap between the payment adjustment year and the performance year. So this 2019 payment adjustment is based off of your 2017 performance. The second category that we will be covering in this presentation is the cost category. This builds off of the value-based payment modifier that was recently introduced the last couple of years. Under this, they are developing new cost measures that are hopefully more applicable to patients and physicians groups rather than the ones that were in existence under the value-based modifier program, but these are yet to be seen in detail. You do not report any data for this category. CMS will use administrative claims data and assess your performance based off of the data that you already provide as part of your claims submission. The key thing to note is that the cost category is 0% of your score for 2019, but your 2019 payment adjustment based off your 2017 performance. So you don't have to do anything for the cost category this year, but the cost category does get weighted more and more heavily each year. So it will be weighted beginning with 2018 performance and then will increase beginning with 2019 performance year. You have several reporting mechanisms and options for submitting your data through the quality and cost category. If you're submitting as an individual or group for the quality category, you have the Claims Qualified Clinical Data Registry, which is QCDR, a qualified registry, your EHR that you are currently using are all available. Additionally, for groups, there is the CMS web interface option for groups of 25 or more eligible clinicians, or the CMS approved server vendor for CAPS, which we'll discuss in later. For the cost category, again, you do not submit anything. CMS will just be using your administrative claims data at the individual and group level. Determining the best reporting option and mechanism, there are a lot of things that you should take into consideration before making that determination. And here in this slide, we have laid out the pros and cons for each mechanism. We advise that you go through this in detail and consider where your practice is currently and assess which one of these is a more feasible option and would help satisfy the reporting requirements. 2017 transition near minimum reporting options. As many of you have probably heard by now, CMS is offering some flexibility in 2017. There are 4 options for participation essentially for the MIPS track. You either don't participate, which means you submit no data, and that will result in a negative 4% payment adjustment in 2019. We don't recommend this option, seeing as the next option, the test option, is a very low bar and will help you avoid a negative payment adjustment by just submitting any data, a minimum amount of data for 2017. You then have the partial to full year submission options. For these, you will avoid the negative payment adjustment, and you will be eligible for a maximum positive payment adjustment. You are eligible for that maximum positive payment adjustment under the partial and full year because what CMS is looking at is not the length of your reporting, but they're looking at the quality of the reporting. So it's based off of your scores in each of the categories, and your overall score for MIPS will then determine whether or not you receive the positive payment adjustment. And if you score highly in 90 days, that will be taken into account and will not deter you from receiving that payment. Options for minimal test participation in 2017. Again, if you submit something, you avoid a negative payment adjustment. So please go with this option. There are 3 ways to satisfy this. You can satisfy it by reporting something for quality improvement activities or the advancing care information or ACI category. For quality, all you have to do is report data for 1 patient for 1 quality measure. And this can be reported through the claims that you are currently submitting to CMS for payment. However, we do recommend that you submit additional data, more than 1 patient, just in case something gets lost in the crosswires. You may have reported the incorrect code, or CMS may not have noticed it with 1 G code. So we recommend reporting at least for a couple of more patients to help ensure that the penalty is avoided. Improvement activities, you just need to report 1 improvement activity, which we will discuss in later sessions as we mentioned earlier. And this can be completed through attestation on the CMS website. And then for the advancing care information, you just need to report 1 patient for each of the required base measures. The number of base measures depends on the version of cert that you have, or certified EHR technology. So it's 4 or 5, and you just report 1 patient for each of these 4 or 5 measures, and it can be a different patient for each, but you need to report those base measures to receive the score. Again, with a partial 90-year, we recommend if you can go beyond the test option and be eligible to receive at least somewhat of a positive payment adjustment, that would be a good route to go down. So the MIPS quality category. The quality categories, this is for individual and small group reporting. The MIPS quality category is 60% of your final MIPS score in 2017. The total possible points you can earn is 10 times the number of measures you report. So if you report 6 measures, for example, your maximum points will be 60 points. You must report a minimum of 6 individual measures or report a specialty-specific measure set. Those are your 2 options here. If you report the 6 individual measures, out of those, 1 must be an outcome measure or a high priority measure if an outcome measure is not available. If you report the specialty specific measure set, you just have to report the measures that are in that measure set. You must report each measure for 50% of applicable patients. We will get into that detail in the next slide. And for groups of 16 or more with at least 200 cases that meet the all-cause readmission measure, this measure will automatically be calculated using your administrative claims data and will be counted in addition to the individual measures that you are already reporting. So for example, if you're reporting 6 measures as a group and you have met the requirements for the all-cause readmission measure, so that measure counts for you as well, then your total maximum points will then be 70 for the 7 measures because each measure is 10 points. Your reporting mechanisms are listed there, which we have covered, and how you are scored for this category. You receive 3 to 10 points for each measure. You will receive at least 3 points for submitting some information on the measure, and then you can receive up to 10 points, the maximum number of points, based off of your performance in that measure compared to the benchmark for that measure. You may also earn bonus points for reporting additional high priority measures. Key thing to note here is that the score for these measures will be counted in your numerator, so the measure points, but they won't count in the denominator. So your denominator will stay the same. So for example, if you report 6 measures and you report 2 additional high priority measures, in addition to the 6 that you already had, your your score will then be based off of your points for the 8 measures together out of 60 points total. Next, quality category group reporting options. So for groups of 25 or more physicians, you have the CMS web interface option. By going with this option, you are agreeing to report all 15 web interface quality measures. This eliminates the need to go through and search for specific measures that are applicable to your practice. And you would satisfy the quality performance category by going this route. However, the registration for this must be completed by June 2017. Another option for groups is the Consumer Assessment of Healthcare Providers and Systems, or CAPS survey for MIPS. This is an optional survey for groups of 2 or more eligible clinicians reporting as a group. The CAPS survey includes a total of 12 summary measures, but it's key to note that those 12 summary measures only count collectively as one measure for the quality category. And they satisfy the high priority measure requirement, but you would still need to report at least 5 additional measures to meet the 6 measure minimum for the quality category. And the CAP survey can only be submitted using a CMS approved vendor. So you will then need to select a different submission method or a reporting mechanism to submit the other 5 measures. Again, for the registration for this is also June 30th, 2017. So what do we mean by you must report the measure for at least 50% of applicable patients? What that means is that you must report the measure for 50% of the patients that meet the denominator criteria for that measure. So for example, if we are using the tobacco use screening cessation intervention measure, I believe the denominator requirements are the patient is 18 and older and has an office visit, and you ask the patient whether or not they have, whether or not they are a smoker or use tobacco products. So if you have 100 patients that meet the denominator criteria for that measure, then the 50% of applicable patients required would be met if you report some level of data for at least 50 of those 100 patients that meet those denominator requirements. This would include whether you conducted the quality activity or not. So for example, whether you conducted a screening cessation intervention or not. So let's say you had 100 patients and you report data for 50 of those patients. That 50 could be broken down that you conducted a smoking cessation and screening for 24 of those patients and did not for the other 26, but you did report data for that measure for 50 patients. So who counts towards the applicable patients for the denominator? This depends on your reporting mechanism. If you're using claims and the CAPS, it is only Medicare Part B patients. If you are using a qualified clinical data registry, a qualified registry, or an EHR, then all payers patients are included, and this would include Medicare. So all the patients that you see that meet the denominator requirements for that criteria will be included here. So key thing to note is that this is not your performance score. The 50% of applicable patients is different than the performance score. The 50% of applicable patients is a data completeness criteria, which must be satisfied for you to receive a performance score. The performance score, in turn, is how often or how well you did in that measure performing the required quality improvement activity. So how is a performance score determined? For each measure, it's determined by looking at the numbers that looking at the number of patients that meet the denominator criteria, and for whom you reported that measure and who are not excluded, and seeing for how many of those patients you performed a quality activity and could satisfy the measure, which is the numerator. So there are some patients that might meet the denominator criteria for the data completeness criteria, but they may be excluded from the denominator due to measure specifications. So again, these patients would count toward data completeness, but they do not count towards the performance score. And some measures may have more than one quality activity that can satisfy the measure, and these are denoted as performance met activities in the CMS measure specifications documents. Now, we understand this is very confusing. We try to break this down. What we advise you to do is, once you have found the measures that you would like to report on the CMS website, then you go and download the CMS measure specifications for these measures and look through and see what the denominator criteria are and what the numerators criteria would satisfy that measure. There's likely that some of your specialty societies may already be doing this, so it would be a good resource to go to their websites and see specifically for your specialty what those requirements and measures would be. We at PAI will be putting out some of this information, and it's available on our website for some more broadly applicable measures, so you can get a sense of that. Then once you have your numerator and denominator, that score will be compared to the benchmark for the measure, and then you'll receive points for that measure from 3 to 10 based off of how you performed in relation to that benchmark. So we lay that out here. Topped out measures, these will not be scored differently in 2017, but it is something to keep in mind for 2018 and going forward. Generally, these are measures in which all physicians perform extremely well. So CMS will be looking at measures that seem to be essentially low-hanging fruit that are easy to satisfy. So 95% or higher performance in these measures across the board would then signal to CMS that these measures need to be scored differently. How they will be scored differently will be detailed going forward. So just something to keep an eye out for beginning in 2018, but nothing you need to concern yourself with at this point. Quality category individual measures. I will now hand it back over to Ray to go through the measure selection process.
Thank you, Priya. So what are the quality category individual measures? Currently, for 2017 reporting, there are 271 MIPS individual measures, and these span across all specialties as well as settings. How can physicians find those? They are located on CMS's QPP website, which is listed on slide number 23. And there is a search tool that we will show on the next slide where you can filter and list the applicable measures. In addition to that, there will be more measures that will come to be reportable through QCDRs that are not included as a part of the CMS MIPS measure list of 271. And QCDRs could be specialty, condition, treatment specific, etc. Each QCDR will offer up to 30 measures, and these again are non-MIPS measures in addition to those MIPS measures, and these may be more applicable and meaningful for you as physicians. And a full list of QCDRs and their measures will be available this spring. Alternatively, you as physicians can report one of 30 specialty-specific measure sets, which we will discuss again on the next slide. There are 30 specialty-specific sets available, which are listed at the bottom of the slide, beginning with allergy and immunology and going all the way through to vascular surgery. Some of the measure sets contain less than 6 measures. In this case, you're only required to report on those measures that are applicable. For example, if a measure set has 5 and only 3 of those 5 are applicable to your practice, you're only required to report those 3 that are applicable. And some measure sets contain more than 6, and in that case, you're only required to report on 6 measures. However, it's important to keep in mind that one of those must be an outcome or high priority measure, and all measure sets include at least one outcome or high priority measure. Now back to the CMS measure search tool, where you can filter as well as find more easily a way in which you can determine where those 271 measures are. The MIPS measures are available on the QPP website, and there are 3 options in which you can find these. Option 1 is to determine if a specialty measure set is available. If it's available, you should review if the measures and determine the applicability to your practice. If less than 6 measures, again, you should be reporting on all 6. And if more than 6, you should select at least 6. And remember that 1 must be outcomes or high priority if an outcome measure is not available. Option 2, you should search by the data submission method available and most convenient for your practice. So as you'll see in the search tool diagram, you can search based upon whether the data submission method is claims or EHR or registry, for example. And option 3, you can search by a key term applicable to your specialty or practice. For example, you can search by condition or diagnosis or treatment. This is intended to make it much easier for you to filter through those 271 MIPS measures that are currently available to you. The MIPS cost category, the second category that we will discuss today. In 2017, as was mentioned before, the weight of the category is reduced to 0% of your final score. In 2018, the category will be 10% of your final score. The reporting requirements and mechanisms for this particular category of cost, no data is going to be submitted on specific measures. What CMS will instead do is they will use administrative claims data to assess your performance. New cost measures are being developed, and some of those possible measures will be Medicare spending per beneficiary, total per capita cost, episode-based measures, as well as patient condition groups and patient relationship codes. And the score, again, will be determined through CMS's use of administrative claims data to calculate that measure performance. And although the cost category will not be scored for 2017, what CMS will do in order to help you as you prepare for payment adjustments in the future beyond 2019 is they will provide you with feedback on your performance using that administrative claims data, but it will not affect your 2017 performance score for your 2019 payment adjustment. So total points earned will be divided by maximum points available, which will then equal your cost score, and it'll be 10% of your final score. But again, that does not begin until 2018. And for 2017, that will be at 0. I'll hand it back to Priya to talk through the performance and payment.
Thanks, Trey. So as the timeline shows, the performance period began January 1st, 2017. Some keynotes to note here are the last day to begin your 90-day reporting period if you're interested in the partial year submission for the quality category is late February 2018. Sorry, that's the last day is October 2nd, 2017 is the last day to begin your 90-day reporting period for participation in MIPS. Another thing to note here is that the registration deadline for the CMS web interface and the CAPS is June 30th, 2017. And CMS has published a list of 2017 qualified registries and qualified clinical data registries, QCDRs, in May or April, so that we can expect to see that soon as well. Another deadline is important to note: if you are submitting data using the claims method, the last day that 2017 claims will be processed for the 2019 payment adjustment will be late February 2018. And the deadline for submitting your 2017 data using a QCDR, a qualified registry, EHR, CMS web interface will be sometime in March of 2018. The exact deadline will depend on the vendor that you are using, so please check in with them about the details there. Once you submit your data, CMS will provide feedback reports sometime in fall of 2018, and then based off of that, you will either receive a negative payment adjustment, a neutral payment adjustment, which means payments are as they would be, or a positive payment adjustment beginning in 2019 of your Medicare fee-for-service claims. Next steps and looking forward. So should you select the MIPS pathway? The first thing is to determine whether you are exempt from MIPS participation, or do you fall into one of those three categories? Are you newly enrolled Medicare physician? Do you not exceed the low volume thresholds, or are you participating in advanced APM, an alternative payment model option that exempts you from participation in MIPS? If you determine you are subject to MIPS, the next thing is to decide what your quality reporting pace for 2017 will be, and you must do this by evaluating your practice readiness. Again, if you can at least do the test, that is recommended, but if you can do something more and at least complete the 90-day period, and the last day to begin that is October 2nd of this year, 2017, then that should be another option that you can pursue to try to be eligible to receive somewhat of a positive payment adjustment. The third is then selecting the best reporting mechanism. While you must report as an individual or group across all four reporting categories for MIPS, you do not have to participate in each category and submit the data the same, using the same reporting mechanism. For example, you can submit data for quality using your claims and data for the ACI category using your EHR, and submit your improvement activities using the attestation website. So determining what the best reporting mechanism is for your practice, and then doing that across the board and across for each category as well. See if there's a qualified clinical data registry that is appropriate for your practice. It may have more applicable measures available than are currently available under the CMS MIPS measures listed, and determine what new processes and workflows will need to be put in place to meet the reporting requirements. You may have to reorganize and restructure your current practice to meet these requirements and make it more efficient for you. And then determine if you have access to an EHR. While an EHR is not required, it is an option that you may want to pursue, as this is something that's being pushed forward for CMS. But is not required, and certainly not necessary to required to avoid a negative payment adjustment in 2017 at least. So going forward, you may have other implications, but for 2017, you can do without an EHR. And then consider whether an advanced APM option is feasible for your practice. And we will go into that in a later session, but advanced APMs are other options that eliminate many of these reporting burdens that may be associated with the MIPS category. And those would be, you would receive a higher payment incentive and payment adjustment theoretically under those according to the MIPS, the QPP program. And what PAI Health Screening resources will be available to help. So going forward, this session is just one of the sessions that we've had. We have one on QPP overview, another will be on MIPS APMs. We have another one available, Advanced APM, another on Advancing Care Information Improvement Activities, which does a deeper dive into all of those. So we'll have more on the scoring, which are available on PAI's QPP website resource. And we're developing additional guides to really help hone down on the specific questions that we have been receiving. There is a searchable FAQ document, which is updated continuously and will be on an ongoing basis with some important questions that have been coming our way. And so regular emails will be provided to the PAI membership to keep them apprised of what's going on in CMS on the MIPS and Advanced APM paths. We'll now take a few questions that we have been receiving and answer those.
To say the least, the quality payment program is complex, as you can tell. One of the first questions that we've been receiving is what happens if I choose not to report any data to MIPS? The answer to that is you'll receive a negative payment adjustment. And as was mentioned earlier, it's fairly easy to avoid those negative adjustments. So we really do recommend that you submit data for at least a few patients in order to avoid that negative adjustment.
Second, depending on your level of participation, may be eligible to receive a positive payment adjustment. So there's opportunity to have a corner. And your practice is likely already engaged in some of these quality improvement activities that we have discussed. And then another category is such as improvement activities. So where can you measure, see what those requirements are and to receive credit and a positive payment adjustment for doing what you're already doing and provide high quality care to your patients.
Do you have a choice on what you want to report for each of the MIPS categories? Yes, you absolutely can select a measure that you would like to report for each category. However, there are certainly some limitations. For the quality category, you can select whether to report a specialty measure set or report individual measures, as we talked about in this webinar. You can select any individual measures that you can appropriate for your practice. However, at least one of those has to be an outcome measure or a high priority measure. You can report any improvement activities to meet the threshold scores, and even for ACI, where you must report the required base measures for at least one patient, you have flexibility in the measures you report beyond that for additional points. And again, as was mentioned, we'll get into more detail on the API category as well as the improvement activity category in another tutorial coming up.
So another question we received is, I previously used several details of for PPRS. Did I use the exact same instrument? Good question. So generally, quality category does build off of the PPRS program and does include many of the same measures from PPRS program. So your process would be the same in terms of where you put the models, things, and etc. However, we recommend that the CMS measures for the measures that you're reporting to ensure that you're reporting correct details and appropriate details on the that you were reporting under. So in case there's any updates, you want to make sure that you check that. And as you mentioned, the CMS measures specifically are available on the CMS website and education and news tab. The file you will want to download is called the quality measures available under the for registration or as an section. It's a zip file, and in that zip file, the measure specifications are listed for each measure, and it's divided by, it's again, further divided by change for registry.
Another question we received is regarding some of the reporting mechanisms. What's the difference between a qualified registry and a qualified clinical data registry? A qualified registry is a registry that is simply used for reporting measures. And on the other hand, QCDR, or a qualified clinical data registry, it's a registry that will usually collect additional data. And that additional data, for example, is for a specific specialty, diagnosis, or treatment. So QCDR is a little bit more in-depth or advanced than a qualified registry.
And the last question we'll be answering now is the logo actually based on what was built in 2016 or will it be for 2017? Another great question. So CMS, as I mentioned, will be available to see, to help you see if you are exempt from the program. And what people need doing to determine this is it will calculate if you have installed for 12 months from September 2015 to August 2016 with a 60-day period. So there's a period. So that'll be the first eligibility determination. The second one for the first one. So the first time for August 2016 and from September 2016 to August 2017 the 60-day period. So essentially what CMS is doing is they are using previous year's claims data to project whether your practice will exceed the low level threshold for 2017. We'll be using previous year's each year. But generally, if you're looking at last year's claims data, Medicare, senior you're safe keep an eye out for that we have to
And on behalf of both the Physicians Advocacy Institute and Healthstarians, thank you for joining us in navigating Medicare.